Well, welcome everyone to the EKG case for the week of August 6th, 2012. And over the past couple of weeks, we've had some relatively longer cases. This week, we've got a short and sweet one. And this case was sent to us by Mike Sheriff. Mike is a paramedic with the Mecklenburg EMS agency in Charlotte, North Carolina. And dare I say, Mike is actually a bit of an EKG nerd, which I love to say. And he has sent me some very nice emails and some nice cases over the past 1 or 2 years or so. And this was a great case that he sent me not too long ago that I thought would be really great. It's a short and quick case. Mike got called to the residence of a 48-year-old guy who had presented with chest pain or was complaining of chest pain. He had a syncopal episode, but upon arrival, I think he was awake, but he was still persistently complaining of chest pain. So Mike and his crew got a quick 12-lead EKG, and the EKG machine is reading this as completely normal. It's normal sinus rhythm. There's not a whole lot to worry about, right? Well, Mike took a look at this, and Mike was actually worried about something. He was worried about something in a lead that we don't normally pay much attention to. It was actually lead AVL. Now, what is it in lead AVL that had Mike worried? Well, if you take a close look at lead AVL, remember normally the ST segment should be fairly isoelectric and flat. If you look carefully, the ST segment is a little bit depressed, and it's actually just a little downsloping. Now I'm going to exaggerate this just to show you what I'm talking about. It's not quite that downsloping, but you'll notice that that ST segment does downslope just a little bit. Now, who cares about ST segment downsloping? It almost looks like it's downsloping into a flipped T wave. There is an upright T wave there, but that downsloping and almost biphasic appearance to that T wave is a bit concerning. Now, when you look over in the inferior leads also, whenever you look at AVL, always take another look also at the inferior leads. You might notice that there's just a tad bit, and I'm seriously saying tad bit, of ST segment elevation in those inferior leads. Probably not even a 0.5 millimeter of ST segment elevation. So who in the world is going to pay attention to a 0.5 millimeter of ST segment elevation? Your EKG machine is not going to pay attention to 0.5 millimeter. Most EKG machines are programmed so that they will only pick up ischemia or infarction when the ST elevation or depression is at least 1 full millimeter. So you can be having an acute coronary syndrome with ST elevation or depression of a 0.5 millimeter or 0.9 millimeters, and your EKG machine at most is going to call it non-specific, or in this case, it'll just plain call it normal. But Mike knew enough to not follow the EKG machine interpretation. He was concerned about lead AVL as a possible early marker of inferior wall ischemia. And by the way, how did he know about that? Well, we've talked about this before on this EKG Weekly podcast or videocast. If you go back through the files, look at October 30th, 2011. The EKG case of the week from October 30th, 2011 was a full discussion all about lead AVL and how mild abnormalities in lead AVL can predict impending inferior wall STEMIs. Now, let me just give you a minute of background on that. For decades, literally, some of the EKG gurus like Henry Marriott and Edward Chung and some of the other big-name cardiologists out there have talked about lead AVL and how ST segment downsloping or T-wave inversions in AVL can sometimes be the earliest marker of an impending inferior wall MI. Now recall that when patients have inferior wall STEMIs, the most common lead in which you see reciprocal changes is lead AVL. So essentially, what these EKG gurus have taught us is that sometimes when a person's having a STEMI, the first EKG abnormality that occurs is not the ST elevation. The first EKG abnormality occurs in that occurs in a STEMI sometimes is the reciprocal change. Sometimes reciprocal changes occur first, then the STs start to rise. And that's exactly what happens oftentimes in inferior wall STEMIs. In inferior wall STEMIs, what oftentimes will happen is that you get reciprocal changes in lead AVL, and then a short time later, then the ST segments from the inferior leads, then they start to rise 5, 10, 15, 20 minutes later. So that's what Mike was thinking about. Is this an early inferior wall MI? So what do? How do you know? You know what? You do something very simple, very quick, very cheap. You simply repeat the 12-lead EKG and see if anything's evolving. So that's what he did. 9 minutes later, that's how quick Mike was working. 9 minutes later, he repeated that 12-lead EKG, and what do you know? AVL is looking worse. Now, if you look at the inferior leads, there's still no more ST segment elevation than there was in the first EKG, but there is a significant change. What you'll notice is the morphology of the T waves is starting to become very, very straight. Remember, a normal T wave morphology, much like V3, normally T waves should be concave upwards. Take a look at V2 and V3. Those are nice and normal, okay? Normal T waves should go concave upwards. These T waves in the inferior leads have become very straight. We've talked about that on the EKG series, a weekly series as well. When T waves start looking very straight, it's oftentimes an early marker of ischemia. So combining that AVL abnormality, the reciprocal changes in AVL, plus the straightening on the initial part of those T waves, Mike was right here able to diagnose an inferior wall STEMI, or confirm an inferior wall STEMI. The EKG machine, by the way, still is not calling this STEMI, so he diverted the patient to a cath center instead of a non-cath center, and then when they got there, they repeat another 12-lead EKG. Now it's 7:44 a.m., and now you've clearly got the inferior STEMI. You're starting to get some cues out there, and AVL has progressed a little bit more. The EKG machine finally called this EKG a true inferior wall STEMI, but Mike knew what was happening half an hour earlier because he knew and paid attention to lead AVL. So very, very simple take-home point. And the two take-home points that I'll give you, number one, when you're seeing some abnormalities in lead AVL, ST segment downsloping or a flip T wave in AVL, in a patient actively having chest pain, you've got to worry that that might be the first marker of an impending inferior wall STEMI. If you want more information about that, go to October 30th, 2011, EKG case of the week. Just scroll backwards and you'll find it. You get a full discussion about that. The second take-home point is a more generic point. Whenever you see some type of abnormalities on the 12-lead EKG, even subtle abnormalities, in a person who's actively having chest pain, get serial EKGs. Even though that first EKG may be non-diagnostic, your serial EKGs over the next 10, 20, 30 minutes or so can become diagnostic, and you just might save a life, just the way Mike Sheriff did. Or even if he didn't save this patient's life, he certainly saved a lot of time in making the diagnosis, because had he not picked up the abnormality and gotten serial EKGs, this patient might very well have ended up at a non-cath lab facility, and then you've got all that extra time of trying to transfer the patient, or you might have to use a less ideal treatment, thrombolytics. So kudos to Mike Sheriff for making this subtle pickup and for getting the serial EKGs. You really did this patient a huge favor. And again, thanks to Mike Sheriff for sending me this great case to share with everyone out there. I hope this case was helpful to you all, and I look forward to talking to you next week. Bye for now.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
A pericardial effusion can be visualized best from the subcostal window, looking through the liver. An effusion will look like an anechoic stripe surrounding the heart in this location. Here's an example of a small pericardial effusion. In this particular effusion, there's no evidence of pericardial tamponade, which is, of course, the thing we are most concerned about, and the reason for performing a pericardiocentesis. Pericardial tamponade can be visualized on ultrasound, but it's not 100% sensitive, so if a patient has a good clinical presentation in the presence of an effusion, you really have to worry about tamponade until proven otherwise. When we think about pericardial tamponade with ultrasound, there's three things that we look for. The first and probably the most important is right ventricular collapse. This is an example of right ventricular collapse from a pericardial effusion causing tamponade. Here we see the free wall of the right ventricle is collapsing during diastole. The next thing we look for is the presence of a collapsed LV. So we think that if the patient has a reduction in forward flow because of collapsing of their right ventricle, the LV is therefore not filling. This makes the LV hyperdynamic, meaning that the walls touch during systole. So this patient, for example, has an ejection fraction of approximately 100% because the LV walls are touching during systole. This is because the LV is not filling appropriately because of the lack of forward flow coming from the right side of the heart. The last thing we're looking for is a dilated IVC. If someone doesn't have appropriate forward flow because of lack of filling of the right side of their heart, we expect the blood to back up into the inferior vena cava. To look at this, we're looking at a subcostal window. This is a subcostal long axis window, and you see the effusion here. Here we see the liver, and the IVC is nice, fat, and dilated, and not collapsing at all with respiratory variation, telling me that there is a significant reduction in forward flow. To perform a pericardiocentesis with ultrasound, you're going to need a couple of things. The first and most important is obviously the ultrasound machine, and we can use either the curvilinear abdominal probe if we're performing a subcostal technique, or we can use the thoracic probe or the cardiac probe if we're performing a apical technique or with the subcostal technique. Of course, you'll also want a pericardiocentesis tray. Now, you don't have to have one of these. If you're not placing a catheter, you can simply use a spinal needle and a large syringe. However, if you do want to place a catheter, I recommend you keep a pericardiocentesis tray in your emergency department. There's two particular windows that we use when we perform a pericardiocentesis under ultrasound guidance. That's the subcostal window, which is the more classic window performed usually without ultrasound guidance, and then the apical window, which has gained a good bit of popularity since the use of ultrasound for guiding this procedure. Some people also use a peristernal technique going in the third or fourth intercostal space. However, I prefer not to use this due to the location of the left anterior descending artery. The concept of lacerating that artery just sort of scares me. This is an example of performing an ultrasound-guided pericardiocentesis from the subcostal window. The steps that we mention here are pretty much the same steps that you would use for the apical window, the only difference being the orientation of the ultrasound probe. For this particular example, we're using a curvilinear abdominal probe. However, you could also use the thoracic or phased array probe for this particular image. Here we see we're looking at a heart with a fairly significant diastolic collapse of the right ventricle and a fairly large effusion. We're going to be coming through the liver here, and we're actually visualizing the pericardium through the liver here. I'm going to insert the needle just lateral to the probe to the patient's right side. That way I'll be going through the liver and towards the patient's pericardial sac. As I insert the needle and draw back, I'll get a flash of blood into the syringe. Once I've seen this blood, I'm going to confirm that it appears my needle tip is in my pericardium. After I do that, I'll take the syringe off, and I'll place a wire through the needle into the pericardial sac. Again, confirming that the wire is in the pericardial sac and not the ventricle. I'll use ultrasound for this confirmation. Then I'll slide a dilator over the wire, and finally pass a catheter over the wire and remove the wire. At this point, I can place the wire to downdrain to drain the pericardial effusion. Here's an example of a real-time performed pericardial effusion. Here we're using the phased array probe from a subcostal window, and you can see the needle coming in just about right here. We see we've popped through the pericardium, and once we pop through the pericardium, we're going to start advancing our wire down. You can see the wire pushing down on the right ventricular free wall here as it goes into the pericardial sac. After the wire, we'll of course push the dilator over the wire. Here we see the dilator coming in. And then finally, the catheter will be placed over the wire into the pericardial sac. Once the catheter is in place and it's hooked up to downdrain, you can actually see the pericardial effusion diminish in size. And here we can see that pericardial effusion getting much smaller. In addition to the subcostal window, you can also use the apical 4-chamber window. For this particular window, I'll again place the needle just lateral to the probe. However, this time I'm going to come from a medial orientation directed towards the apex of the heart. I'll again be able to see virtually the same thing that we saw with the last image. However, we'll of course use the phased array probe in this instance because it's much easier to visualize through the rib spaces with a phased array probe rather than with a curved linear. A few tips and tricks. So agitated saline is a great technique for making sure that you're actually in the pericardial sac as opposed to placing the needle or the wire into a ventricle. Here's an example of injecting agitated saline into the pericardium once you have the needle in what you believe is the pericardium. You can see how the agitated saline lights up and is extremely hyperechoic in the pericardial sac here. If we were inside a ventricle, say the left ventricle for example, we would see the left ventricle light up as opposed to remaining dark here. Agitated saline can be a great way to confirm that you're in the right location, especially if you're trying to tap a small pericardial effusion or if you're just not very comfortable with placing a large dilator into a ventricle. Needle in plane technique. Some people talk about using the needle out of plane technique, which would mean going with the needle through the center of the probe. However, I prefer having the needle come in laterally so that we have the needle in plane and in view the entire time. This allows us to see the needle tip and really know where it is in space. So I'll have the needle come in just lateral to the probe, and then that way I know where to expect it on my screen. I would expect the needle coming in just here laterally going towards the pericardial sac. Again, I'm going to have the needle actually come in right next to the probe marker. That way I know to expect the needle coming from the probe marker as seen here. Go where the fluid is. It's important to remember that with pericardiocentesis there are no margin for error as possible. So wherever the pericardial effusion is the thickest is probably where you should go with your needle. If that happens to be peristernal, even though Malin said don't do it on his little podcast, go for it. Whatever you think, whatever you're most comfortable with. So apical, subcostal, peristernal, wherever that effusion is the largest is probably going to give you the best chance of success without taking out a ventricle and placing a catheter in someone's aorta.
Some good news and some bad news. The bad news is we only have a couple spots left for CastleFest.
So since it's obvious that some people are not going to get to come who want this education, we found a solution.
Yeah, here's the good news. We're investing in some technology to allow us to stream the whole conference live. All the lectures will be streamed in high quality in real time, so you'll still be able to get a full 16 hours of CME.
And you don't even have to come to Kentucky. Hang out in the castle, go to the bourbon distillery, watch horse racing, and all that nonsense. You can attend via the comfort of your own home.
Actually, you could even watch while at work or while driving in your car. It's going to be streamed live and completely mobile, so you can watch live on your iPhone, your Droid, your iPad, or whatever device you crazy kids have nowadays.
To sign up, go to ultrasoundpodcast.com or castlefest2013.com, and there will be buttons for the virtual attendance.
Now, Mike, that's great, getting to watch while jogging, biking, or sitting on the toilet, but I just thought of something. They won't be able to ask questions and interact with the speakers. What if they've always wanted to ask Weingart what mic setting he uses to sound so smart, sexy, and hammer time cool all simultaneously?
Come on, Matt, we're better than that. Of course you can. We're going to have feeds set up live so you can ask questions in real time, and we will have people responding to them or raising their hands to ask the speaker questions.
So I can ask that stupid question I'm always afraid to ask in person, and no one will know who Bieber fan number 1 is?
That's right. Ask away. Anonymity is nice.
All right, I'm sold. I'm going to attend virtually. I've always dreamed of doing jazzercise and watching Mike Stone teach nerve blocks at the same time. How do I do it again?
Go to ultrasoundpodcast.com or castlefest2013.com and sign up for virtual attendance. There are a few different packages to choose from, all guaranteed to delight.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.